welcome to this episode of the Black Belt Nurse Podcast. So today I'd like to go over with you legislation at the state level and how it affects violence prevention in the healthcare space. Most of what I'm going to go over today is what has been happening in the state of Oregon, which has had a lot of movement in the last year or so. And I'll just say that this is the way it's going to be happening, I think, in the future, is that more and more states are going to start legislating violence prevention programs in the healthcare space, because we keep seeing it about every year that another state will add a requirement for a hospital or health systems or healthcare in general to have some sort of plan for violence prevention. So what I'm going to go over is two bills in the state of Oregon. The first one is Senate Bill 537 or 537, which went into effect in 2025, and also Senate Bill 170. Now that one is very short, and maybe I could hit that one first. In the history of violence prevention in the state of Oregon, there has never been a felony legislation, meaning that it is a felony to assault a healthcare worker, specifically. It's not like we haven't tried. I've been a part of at least 3 or 4 attempts to pass it through our legislation here in Oregon, but there's no appetite for it. It's not the culture for it. We've even heard that there should be no new felonies. Senate Bill 170 in 2025 was a compromise. In a sense, it is a 3 strikes law. And what that means is that the first time you assault somebody who is performing duties of their work, and that's not just healthcare, it's for everybody. The first assault is a misdemeanor, the second one is a misdemeanor, and then the third one is a Class C felony. So it's essentially a 3 strikes law, and that does include workers in healthcare. Now, if you go and watch and read the bill itself, and you go watch the testimony, essentially it's the best compromise that we could have. Now, some groups disagree with it. They felt that it should be a Class C felony if you assault a healthcare worker, because the data is there that the risk for violence and the actual violence in the healthcare setting is real. And it's really more than almost any other profession in the United States, even more than law enforcement, right? So this is the best that we could do. And I get it. It's either all or none, but this seems to be the best compromise. Now, the conundrum then is, how are you tracking if it's a person's first, second, or third? And how do you know if it happened in a different jurisdiction, if the crime was against somebody who was at work or performing their duties at work? We don't know. Who's going to track these? So that remains to be seen, but it is part of the law now. And at least when an assault happens in healthcare, people who are advocating for the victim, or even the victim themselves or the survivor themselves, can go and ask, has this person done this crime to somebody else while they were at work too? And maybe, unfortunately, it might be on the health system or the advocates to actually push for that. But that is the compromise, and that's what went into law in 2025. Now, the real meat is Senate Bill 537, which I have here. And of course, I'll link these in the show description so that you can take a look. You can watch the testimony. You can read the testimony. You can download and read the actual bills and how they're being put into law. Now, I'll just say I've been a part of the process from start to finish, from the bill draft to supporting the bill to helping it pass, to even helping it translate from the Oregon Revised Statutes into the Oregon Administrative Rules. Because the Oregon Revised Statutes say the what, but the Oregon Administrative Rules say the how. And so I've been invited into that process, and I've had the opportunity to give input to both the health authority, the enforcement side, and not only from the health side, or from the OSHA side. So currently I'm in the OSHA side. We're finalizing that, and that's been taking a while, but we did the health system side already. So there's a lot in this bill. And for context, in Oregon, we've had a violence prevention requirement since about 2007. So it passed the legislature in 2007. 2008 is when they did a study of all hospitals, and then they released that report in 2009. And of course, back then, violence was a problem. So the law back then has required that healthcare has to have a violence prevention program. You have to do an assessment of your facility, of your health system, looking for safety and security issues. You also have to provide education, and there are some specifics in that law of what you need to provide. You also need to teach physical skills. You also need to teach how to control and restrain. And you also cannot sanction somebody if they do use those skills, including self-defense, in an appropriate manner. So this law, Senate Bill 537, expands our safety of healthcare employees law. And it does it in a couple ways. It expands the requirement not only for hospitals to have a violence prevention program, but now it includes home health and hospice. Those two entities got added to the law, so they have to comply. And there are certain elements that got added as well. And I'm going to read through some of these just to kind of get what's been added and what has been strengthened. So, as part of a violence prevention program, like I said, it requires periodic security and safety assessments, including now threats of workplace violence, not actual incidents of workplace violence, but now threats have to be considered. There needs to be a violence prevention and protection program for employees based on those assessments. There needs to be training. It used to be on a regular and ongoing basis. It is now changed to annual. So there needs to be some sort of training on an annual basis. And it includes now not only every employee, but if there's any contracted security personnel who work on the premises. So they are now included into this measure. It also mandates that healthcare systems and now home health and hospice have to measure the frequency of assaults. We call this the assault log. So you have to maintain it separate from your OSHA 300 log, which is injuries, but noting that some can be on the assault log and they can be on the OSHA 300 log. So now we have to not only measure actual assaults, but even attempts of workplace violence are supposed to be captured. And every facility has to retain those records for 5 years. Now, in the history, if you reported or collected reports and data, you didn't have to do anything with it. But now it is the requirement of Oregon OSHA, or the Oregon Department of Consumer and Business Services. They have to collect some data and provide an annual report to the Oregon legislature every year. So it behooves healthcare systems and hospitals to collect that data in such a way that they could simply hand it over to Oregon OSHA when they come and ask for that data. All right. And new is a part of your violence prevention program has to include investigation as well as analysis of root causes, as well as the consequences of workplace violence, and including a plan for addressing those root causes that you find, and the findings on the extent to which the security considerations described are implemented to mitigate the risk for violence. So root cause, like what happened, what are you doing about it, needs to be included into your program. You also need a response plan. So if workplace violence happens, you need some sort of documented way of how you plan on doing it. That includes, are you considering the physical attributes of the healthcare setting? Are you looking at staffing plans? That's new. Personnel policies. What are you going to do for first aid and emergency procedures as somebody is injured? You need to have a procedure for how do you report a workplace violence incident. And you need to provide education and training for, and these are new, how you are going to conduct investigations. So employees need to know how you're going to do this. How are you going to identify caregivers who are involved in a workplace violence incident? How are you going to conduct a post-incident employee interview for the purposes of gathering factual details about the actual incident? And also, how are you going to implement post-incident response strategies that address the provision of first aid and also trauma counseling? So that all has to be part of your program. You also have to provide workplace violence prevention and protection training to new hires within 90 days of hire. Now, that's been on the law. What's new in the law is that you have to provide training for temporary employees within 14 days. You also need to provide that there is a person with the appropriate knowledge and expertise to be available to employees to answer questions and or clarify any aspects of the comprehensive workplace violence prevention protection training through in-person interactions, phone, electronic mail, or other means. So you need to have somebody who is knowledgeable about the program. Maybe it's that program manager, maybe it's that executive sponsor, that executive leader who is available to employees to answer and address those questions when they come up. And you have to provide your violence prevention plan to employees. It could be a written copy. The law says a written copy needs to be provided, But there's debate of, can't we just make it available? Can't they look at the policy online? That remains to be seen, and that is something that we are debating on the OSHA side currently. And for newly hired employees, the healthcare employer will provide a copy of the plan within 30 calendar days from the date of hire. So they mean business now, right? You have to have a plan. You have to provide education. You have to have a plan for how you investigate, how you keep track of things, even how you're going to follow up and provide care and provide resources to employees after these happen. Look, it's not a mystery. Workplace violence in healthcare is not a mystery, right? You should not be surprised when it happens. It's not if it happens, it's when it happens. So it behooves everybody, and this is not just in Oregon, it behooves everybody probably throughout the world, have a plan, right? It's going to happen. So if you can plan for it and hopefully implement some tools to maybe predict or maybe be able to de-escalate early or find some of these things out before they happen, that's the better thing. And so moving on to the next section that has to do with reporting, there's a little bit more detail because the Department of Consumer Business Services, which is Oregon OSHA, they need to collect some data. There's some minimal things, not necessarily details of what happened in a workplace violence incident, but more higher level data. And they need to develop a report and submit it to the Oregon legislature on an annual basis so we can trend and track and see what's happening in the state, because that data might influence further legislation. A new thing is identification badges, that you do not have to have your last name on your identification badge unless you request it or unless some sort of federal law requires you to. You do not have to have your last name on your badge. Now, that is with the goal to prevent somebody from going out and searching and stalking and even cyber stalking employees, because we are easy to find sometimes. And you hear those threats while the person is in care. I'm going to find you and I'm going to do whatever, right? So this hopefully can minimize that risk a little bit. Now, the big meat of this one is a flagging system. So if you work in healthcare, home hospice, or home health, or the hospital setting, acute care setting in general, you now need to have a flagging system, meaning that you need to be able to communicate a person's risk or violence to the next person, even to the next entity, from the hospital setting to the home healthcare setting. There has to be a method for you to connect and exchange information. So it's not only within the entity itself, but across the entities needs to have some sort of communication. So when you talk about flags, there's two different ones. You talk about the electronic health record flag that is in the patient's chart, and then you also have the visual flag, which is a paper-based or some sort of visual system that alerts somebody that this patient is a risk for violence. It's supposed to facilitate immediate recognition of potential threats of violence or disruptive behavior without needing to have access to the medical record. Because you think in the healthcare system, we have plenty of people that might go into a patient's room that are not clinical, that are not in the electronic health record. And that can be nutrition services, that can be security, that can be housekeeping. You have other people that are not in the medical record all the time, like we are, like caregivers are, that need to know that when they go in, there's a potential risk and that you should probably bring somebody with you or talk to a caregiver before you actually enter that room. It's not only for those people who are not in the medical record, it's for everybody. Even the people who are in the medical record sometimes need that extra flag. Now, people make arguments. So like people don't watch signs, they don't look at signs, they ignore them. That is true. But we want to give every opportunity to communicate an actual risk that exists in order to help keep not only that person safe, but also the patient safe. So there's a debate whether visual flags, they can be easily implemented in the hospital setting, but how do you do a visual flag for home health visit? What does that look like? Is that even possible? So that's one question that we're struggling with. So each covered entity, meaning the hospital, hospice, home health, you need to establish protocols and procedures regarding the implementation and the use of flags. At minimum, these protocols and procedures must address for healthcare records and visual flags, criteria and processes for initiation, continuation, inactivation, and reactivation of the flags, You need to have reasons for why you initiate or revise the flag. You need to have specific recommended actions that providers and staff should take when interacting with a flagged individual. We need to figure out what type of person can initiate a flag. Is it just the nurse? Does it need to be a nurse manager? Does it need to be quality management or safety? Ideally, it would be as close to the bedside as possible, but you need to have a plan for that. You need to have training and education requirements for people who are authorized to initiate the electronic health record flag, including training on identifying and preventing bias in the assignment of such flags. Now, if you have established criteria of if this and this and this and this happens, then a flag gets activated, or if you can automate it in some way, such as using a validated assessment tool, and based off of your use of the tool, or maybe the more points that accumulate, the higher the risk level that your electronic health record could help you activate, place the flag, and it could be automated in such a way. Now, that would be ideal. If you could automate it some way, let the electronic health record help you, so to speak, versus you having to do it all on your own, or I think we need a flag. You need more objective data to help initiate a flag versus subjective. Because the more subjective we are, the more likely we can be to get into some bias. You also need to know what are the responsibilities for staff when there is electronic health record flag present. You need processes to evaluate and identify potential threats of violence or disruptive behavior. You need consistent practices for assigning, tracking, monitoring, and documenting information in that flag. You also need processes for reviewing and updating the flags as necessary. You need to determine, should that flag stay on or should that flag come off? You also need to communicate and collaborate about flag conduct or behaviors recorded in the flag. You need safety protocols and precautions for engaging patients with the flag. You also need to consider patient privacy in relation to worker safety, so complying with HIPAA. You also need to document or need supporting documentation for every action on the flag. Essentially, every time you initiate, continue, inactivate, or reactivate, it should be supported by clinical documentation. You need to also have a process for if somebody wants to appeal their flag. Now, typically, people don't know that they have a flag in their electronic health record, but some do find out, some do become aware. So you need an appeal process where they can say, hey, I want this reviewed, or I potentially want this removed. Now, you also need to have the visual flag, right? We talked about the electronic health record flag. Now you need to also have protocols for the visual flag. It's like, when do you put them up? How have you educated people to that? You need consistent processes for that. And you need to know what you cannot do with a flag. You cannot deny admission to a program or service provided by the covered entity to which the patient would otherwise be eligible. You cannot, based on the flag, make decisions regarding their access to care. Based on the flag solely, you cannot prevent or restrict the right of the patient to file a complaint with the appropriate federal or state agency regarding the patient's right to privacy. You also, based solely on the flag, cannot deny or restrict the patient's right to access or obtain their protected health information. You cannot contact, report, or disclose information to law enforcement based solely on the flag. You cannot deny, restrict, or withhold medical or non-medical care that is appropriate for the patient based off solely on the flag. And you cannot punish or penalize the patient based solely on the flag. That language is very specific. It is, and it says, may not take any of the following actions based solely on the presence of an EHR flag. So be careful with that. You can still contact law enforcement if a crime is being committed in the healthcare setting. That is allowed by HIPAA. Now, I happen to work with a healthcare system that already has that flagging process in place. In fact, the law was actually built off of that health system's flagging process as it exists. And like I said in episode 10, that's a good outline of how we established it and what the future looks for that. So go back to episode 10 and watch that if you want to get into the nitty gritty of what healthcare flagging for workplace violence can look like. All right, additional requirements in this law is if you are building a new emergency department or if you're remodeling or doing new construction in the ER, you have to provide some bullet resistant protection. So that is new. So like your intake area, maybe your triage area has to have a physical barrier between a healthcare staff and somebody who's potentially violent as they're coming in. And the rest of the law addresses more specifically the home healthcare setting, what you need to assess when you're doing client intake, how are you going to get information from a hospital setting, and then the specific type of training, which matches the rest of the law that has already existed since 2007. So that's the meat of Senate Bill 537, which is a big step forward in violence prevention in the healthcare space. Now, as far as I know, requiring flagging in healthcare, Oregon is the first state that is doing it. Now, do I foresee that some other states might adopt this? Yeah, because I think communication of violence risk is very important. Where we often come down to safety situations where this happens even in patient safety situation, is that communication can get dropped. And I have actually experienced and seen incidences where the communication wasn't there and somebody got hurt. Somebody got assaulted, whether physically or sexually, it happened. And that was because of a lack of communication. And I go back to the core of why we should be doing flagging for violence in healthcare. It is a communication tool. That is it. It's a communication tool. It is a communication tool to help spread the word, spread awareness of a potential or an actual condition. Now, with that communication can come safer behaviors, not only from staff, but also from the patient. It is to keep the staff safe and to keep the patient safe. It's not there to increase bias. It is not there to unfairly punish somebody for their actions. It is solely there to communicate the risk and provide better care. And that is found in the literature too. You can find that in episodes 7 through 10 of the Black Belt Nurse podcast, where I really get into the details of flagging in the healthcare space. So that's it for today. I appreciate you listening and sticking it out this far. If you find information like this beneficial, please like and subscribe to the channel. Hit that notification button so that you're notified when I drop new episodes. I'm going to try to be more consistent in developing new episodes and getting you good content, because I think we really do need to take the time and explore these deep conversations, the deep level stuff of violence prevention, because I don't see it out there much. And if we're really going to be effective in preventing violence in the healthcare sector, we really need to look deep. We need to have good discussions about public policy and advocacy and how it goes into state law or even federal law in the future, because it is happening. It's going to come to a state near you if it hasn't already. Share the podcast with friends or people that you know are interested in this or struggling with their workplace violence prevention program. Now, with that, if you have questions for me, or if you want to reach out and talk, mull things over, or even want my help, you can reach out to me through my website, blackbeltnurse.com. So until next time, stay safe, and I'll see you in the next episode.